Bismillah ar-Rahman ar-Rahim. Welcome again in this new meeting of Egyptian Society of Nephrology and Transplantation, CME meetings. And I would like first to welcome the recent president of Egyptian Society of Nephrology and Transplantation in this new board period, starting from 2024 to 2027, Professor Ayman al-Rifai, who is joining us today. We are to congratulate him and wish him all the success in this in his residency.
Inshallah.
This is a new meeting of Egyptian Society of Transplantation, CME chapter meetings, and today we are in date with one of CKD MBD meetings. We are to discuss in a new way about similar to a workshop in the form of case presentations, and I am so lucky and honored to have our two co-moderators, Dr. Tariq Tantawi, consultant nephrologist in Mansoura Specialized Hospital, and he is the vice president of Gharbiya Medical Nephrology Association, and one of the Afran Registry Committee members. And the other co-moderators, my dear friend and brother, Professor Muhammad Kamal Nassar, Associate Professor of Nephrology and Transplantation in Mansoura University. Our speaker today is Professor Yasmine Naga, Associate Professor of Nephrology and Medicine in Alexandria University. She will illustrate CKD MBD in many cases, some approaching as far as I know about 4 to 5 cases, and we will open the discussion during the session, but please, we will not open the discussion except after the end of the case. Please, discussion is opened on the chat while she is presenting her case. Please answer on the chat, give your comments on the chat, and we will give a few minutes after each case for discussion before moving to the next one. I will leave the floor to Dr. Tariq to start this meeting, and Dr. Muhammad, and come to you back again with the discussions to go forward and throughout the cases. Thank you very much. Please, Dr. Tariq, take the floor.
Many thanks, Dr. Yasser, for your kind invitation. I'm happy to co-join this and hot issue in our daily practice about chronic kidney disease and mineral ball disorders. Will presented very well by Professor Yasmine Naga, together with my dear brother and friend, Dr. Muhammad Kamal Nassar. Again, we are waiting for a good night with a lot of benefits for our doctors. And also I congratulate my dear brother, Dr. Ayman al-Rifai, for his presence next 3 years for the Egyptian Society of Nephrology and Transplantation. And I speak now for my brother, Dr. Muhammad Nassar.
Thank you, Dr. Tariq. Thank you, Dr. Yasser. It is my great honor to be here today in this prestigious meeting. Actually, it is my honor to introduce my dear friend, Professor Yasmine Naga. Professor Yasmine Naga, Professor of Nephrology and Transplantation, Alexandria University. She is one of the eminent professors of nephrology in Alexandria and Egypt. I think the week before, we heard from her this workshop. Actually, it was very interesting, and I think we'll enjoy it today. Professor Yasmine will speak about CKD MBD, clinical challenges, and case-based discussion. Please, Professor Yasmine.
Thank you, dear colleagues, and I would like to congratulate the Society for the success of the recent Congress, and I personally congratulate also the whole board, the new board, including Dr. Ayman al-Rifai, and also Dr. Yasser Abdelhamid after the elections. And I thank Dr. Yasser also for his continued effort in the continuous medical education. So CKD MBD, to get into the subject, CKD MBD is, as we know, the evolution of renal osteodystrophy after the realization that it's not just bone abnormalities, but it's actually three things that affect patients with chronic kidney disease. There are laboratory abnormalities, there are bone abnormalities, and there is also vascular calcification. And at the core of these three changes that are part of CKD, MBD, there is the poor outcome they are associated with, which is increased cardiovascular disease, increased fractures, and increased mortality. And actually, I think after reviewing all the treatments we're going to discuss, we are not doing a very good job in reducing these outcomes. And most treatments we give do not effectively address these outcomes. So I'm going to base my suggestions, and again, I say that I don't have correct answers for all the cases I'm going to present. They are all suggestions that are open for debate, but they are mainly based on the latest CKD MBD update of the guidelines that were published first in 2009. But actually, the KDIGO guidelines, they only put general rules, and they often cannot be easily implemented in clinical practice. And as I said, different physicians may prescribe different medications for the same patient. So we're going to start with patients in the pre-dialysis stage. This is a 58-year-old man with diabetic kidney disease. He has type 2 diabetes, hypertension, and dyslipidemia. His creatinine is 1.6 milligram per deciliter. Albumin creatinine ratio is 245 milligram per gram creatinine. His medication include SGLT2 inhibitor, DPP4, antihypertensives, and statin. Do you need to screen for CKD MBD? And I encouraged all the attendants to maybe write their answer in the chat. I'm going to follow the chat as we go along. You think we should screen this patient or not? So before saying we should screen him or not, I think most are saying yes, we should convert this creatinine into GFR. And maybe you should do this with every case we see. And actually this mild elevation, it turns out that his GFR is 49.6 milliliter per minute, which puts him in stage 3A. With also albuminuria 2, which actually, according to the KDIGO guidelines, says that we should screen him. But how do we screen such a patient? He's a patient with just mild increase in creatinine. We see a lot of these patients, and actually general practitioners see a lot of these patients. How should we screen these patients? So to get to it, the KDIGO recommend that we begin screening for patients in adults at stage 3A, while in children starting from stage 2. And to screen, they suggest that we measure calcium, phosphorus, parathyroid hormone, and alkaline phosphatase. There's also a separate suggestion that we measure 25-hydroxy cholecalciferol or vitamin D. So vitamin D is actually should be measured in such a case. How frequently should we measure it? They say that it is reasonable to base the frequency of monitoring depending on the presence and magnitude of abnormalities and the rate of progression of chronic kidney disease. They also give reasonable periods of monitoring. And this is, I put it in a table that in stage 3A and 3B, maybe calcium and phosphate every 6 to 12 months, parathyroid hormone based on the baseline level and the CKD progression. In stage 4, we should monitor more closely. And in stage 5, we should monitor, including dialysis, we should monitor every 1 to 3 months calcium and phosphate, and PTH every 3 to 6 months. Alkaline phosphatase, they have not put exact guidelines on how frequently to monitor it, but it should be maybe every 12 months and more frequently with elevated parathyroid hormone. Again, we should increase the frequency. They know that we should increase the frequency in patients with biochemical abnormalities to identify trends, and in patients who we prescribe treatment to monitor the treatment efficacy and the side effects of the treatments we give. So to continue this case, these are his investigations. His parathyroid hormone was slightly elevated and his vitamin D was low. How would you treat such a patient?
Answer on the chat, please. We'll give a few seconds.
So,
okay.
Again, in this patient, I think because of his vitamin D deficiency, we would agree to give vitamin D as a supplementation. Whether to give alpha-calcidol or not, I think the alpha-calcidol is being abused, as we're going to see. It's not recommended in stage 3A and 3B unless it is strongly indicated, and it does not correct vitamin D deficiency. No treatment necessary. I think for calcium and phosphorus, I would agree. But again, the patient has vitamin D deficiency, and there is some evidence that its treatment may benefit. So what is the optimal PTH level in the patient's pre-dialysis? Actually, the KDIGO does not give an answer to this level, but they suggest that if the level is progressively rising or persistently above the upper normal, we should evaluate for modifiable factors, including hyperphosphatemia, hypocalcemia, high phosphate intake, and vitamin D deficiency. Of these factors, vitamin D deficiency is present in this case. And after suggesting that we measure vitamin D, they suggest that if vitamin D deficiency or insufficiency are present, we should treat them according to recommendations given for the general population. And there is actually suggestion to avoid calcitriol and vitamin D analogs, and probably the only vitamin D analog present in Egypt is alpha-calcidol. It should not be routinely used. It should only be reserved in stage 4 and stage 5 in patients with severe and progressive hyperparathyroidism. So again, it is a drug that is frequently abused and given without benefit, and they base this guideline based on that there is no benefit of alpha-calcidol and vitamin D analogs in RCTs, and there is risk of hypercalcemia when given, especially early in CKD. Now, vitamin D deficiency is common in CKD patients, and it is associated with high serum parathyroid hormone, bone mineralization defects up to osteomalacia, and there is also a lot of non-skeletal associations. It's vitamin D deficiency has been associated with cardiovascular disease, with diabetes mellitus and insulin resistance, with multiple sclerosis, with increased autoimmune disease and reduced immunological response. There's also a study that found that low levels that are below 50 nanogram per milliliter are associated with increased risk of progression of CKD and increased mortality. So actually, it may be advised that we correct vitamin D deficiency in most cases. But again, there are no interventional studies that found that it improves outcome. However, its deficiency is associated with outcome. So how do we correct vitamin D deficiency? Again, the latest guidelines in the general population recommend that we replace by either vitamin D2 or D3, either in monthly doses of 200,000 units, or weekly doses of 50,000 units, or daily doses of 6,000 units for 8 weeks, but this interval may be increased or decreased based on the baseline level. So if it's lower, then maybe for 12 weeks. If it's higher or closer to the target, then for 4 weeks only. And it should be given to achieve a blood level of above 30 nanogram per milliliter. After achieving that level, it is recommended to follow up by maintenance dose of 1,500 to 2,000 units per day. What we often miss is that in obese patients, in patients with malabsorption syndrome, and in patients taking medications that affect vitamin D metabolism, And actually, we give a lot of these medications, including proton pump inhibitors, corticosteroids, including other drugs. In these cases, patients need higher doses, between 6,000 to 10,000 units per day. Again, the target is 30 nanogram, and the follow-up maintenance dose in these patients would be 3,000 to 6,000 units per day. The value, again, has not been adequately examined in CKD patients. Also, in the general population, most studies have not found reduced risk except of fractures and of some malignancies. And also the optimal level of circulating vitamin D is unknown. And some studies have suggested that to have normal PTH, actually patients should be at higher target level, maybe more than 40 nanogram per milliliter, and target levels up to 60 nanogram per milliliter are not associated with increased risk. So the patient comes for follow-up 2 years later. He took cholecalciferol for 3 months and continues to take it at a dose of 2,000 units per day, but did not follow up. His new investigations revealed that his GFR has declined. He's now in stage 4. His corrected calcium is 8 milligram per deciliter, and especially in patients with proteinuria or nephrotic syndrome, we should take care of albumin and correct the calcium. Phosphorus is 4.5 milligram per deciliter. PTH is increased. Alkaline phosphatase is increased. His vitamin D deficiency is now normal. What would you suggest would be the next treatment or next treatments? I'll wait for a few seconds for answers. Can answer more than one, give more than one choice. So I see that there are multiple and different answers, and I think there is not a single correct answer here. So if someone chooses no treatment necessary and follows up, I don't think he will be wrong. Phosphate restriction is a very important step, and I see some of you have chosen it. His phosphorus is borderline, and if you give any treatment to raise calcium, it may raise phosphate with it. So phosphate restriction is very important in this patient. And most of you agree that we may, in this patient, start to give calcium carbonate and activated vitamin D, which again may be viable options in this patient. But again, I think that this patient, no treatment necessary would be a viable option, at least for a month, and you follow up the investigations. As we'll see later, that the KDIGO suggests that we treat trends rather than treat absolute values. Giving him calcium plus vitamin D, I think, is correct, but it's very important to add phosphate restriction in the answer. Some have said calcium acetate mid-meal. His phosphorus is not that elevated, so maybe reserve it for later stages. So again, the optimal level is not known, but here we have one of the modifiable risk factors, which is hypocalcemia. A very important point in the KDIGO guidelines is that we should base our treatment on trends rather than absolute and single laboratory values. So in some patients, it may be advised to follow up the patient in 1 month and see how things go. Are they stable at these levels, or do they increase? Again, we said calcitriol is not recommended in stage 3, but now that he is stage 4 with progressive and severe hyperparathyroidism, it may be an option. And they suggest that we examine calcium and phosphate together. We should not assess or correct one alone without examining the phosphate. So here, his calcium was below normal, but his phosphate was at upper range. So any treatment, especially calcitriol, may increase it to above range, which is not preferred in this patient. We used to recommend that we should always calculate the calcium phosphate product, and that it is above 55, then we should not correct the calcium, we should lower the phosphate, but they actually advised against using this. There was no evidence that supports the calcium phosphorus product, but we should examine them together. And it's very important that their recommendation for phosphate, that they suggest lowering elevated values, while in calcium, they do not recommend correcting calcium except in children. In adults, they recommend that we avoid hypercalcemia. And as we will see later, we should avoid hypercalcemia at every stage because it is associated with vascular calcification and hypercalcemia. It may suppress parathyroid hormone and lead to adynamic bone disease. And there's actually a European consensus statement that was just released to recommend calcium, to give recommendation on calcium intake in adults and children with chronic kidney disease. And they said that to weigh it, there is too little calcium leads to bone disease, while too much calcium leads to vascular calcification. And they recommend that the total calcium intake in diet and medications should not exceed, should be at around 800 to 1,000 milligram per day in adults, and should not exceed 1,500 milligram per day to avoid hypercalcemia and risk of vascular calcification. Now, most of these are the calcium preparations that are present in Egypt. Now, I forgot to tell you one thing, 800 to 1,000 milligram, this is already present in the usual diet. So the usual diet it contains 800 to 1,000 milligram per. So again, taking into consideration this, you should not increase the calcium intake more than that by much. Now, calcium carbonate is the most commonly used preparation, it and calcium acetate. Now, if you find here, that is 40% elemental calcium, so 500 milligram tablets includes around 200 milligrams of calcium, while calcium acetate is mainly a phosphorus binder with less calcium, elemental calcium content. Calcium citrate is also present in Egypt, sometimes in tablets form and more in combination with magnesium. Its elemental calcium is low and its phosphorus binding is actually low. So again, generally, we used to be told by our professors that when we are looking for calcium supplementation, calcium carbonate is preferred. It has more elemental calcium. While if we're looking for a phosphate binder, calcium acetate is better, but we have to take care that the elemental calcium plus the calcium in diet does not exceed the 1,500 milligram. So the patient took calcium carbonate once per day, 2 hours after meal, plus alpha-calcidol, and was advised to reduce phosphate intake in diet, but was not compliant, and most of our patients are not very compliant on dietary recommendation. 6 months later, he presents with the following investigations. His corrected calcium is now normal, his phosphorus has risen, his PTH has decreased slightly, and his alkaline phosphatase has decreased slightly. What is or are the most appropriate treatments at this stage? Again, I'll give some time for you to suggest answers. So again, if you're reviewing the chat, I think nobody agrees on what to do. So I think the corrected calcium is normal now, so we should by all means maybe stop calcium supplementation. And again, I forgot to tell you, Bardo, another point that our clinical pharmacists always advise: if we are looking to give calcium as a supplement, it should be given 2 hours after meals to improve its absorption. Stopping alpha-calcidol, I think, may be also advised here because the calcium and the phosphorus are elevated, and this puts the patient at increased risk for vascular calcification. Continuing alpha-calcidol, although will be beneficially for reducing parathyroid hormone, but again, we said it's the target parathyroid hormone in pre-dialysis CKD is not established, and continuing it will raise both calcium and phosphorus. Phosphate restriction is very important. Calcium acetate mid-meal may be an option, but again, it will increase if there is risk of hypercalcemia, and again, there is hypercalcemia already, or there is normal calcium. Giving aluminum hydroxide or non-calcium phosphate binder would be better options at this stage. Giving cinacalcet in pre-dialysis patient can be used, but again, in this case, I think it's a bit premature to start cinacalcet. So phosphorus levels are associated with increase in CKD, MBD, and cardiovascular disease, and mortality also increases with elevated levels of phosphate. However, normalization of phosphate levels has not been proven to improve patients' outcome, maybe because of the tools we use currently, which increase calcium and increase vascular calcification. Again, we should remember we should base our treatment on serial assessment, and we should consider all factors together. Giving treatment, phosphate lowering should be given on progressively and persistently elevated serum phosphate. His phosphate was 4.5, it's now 5.3. And they suggest that we restrict calcium-based phosphate binders because of their risk of hypercalcemia and vascular calcification. But we have to use them in some cases because they are available and they are relatively cheap. They recommend that we avoid long-term use of aluminum-containing phosphate binders, but they can be used for 1 to 2 months at a time, maybe 1 to 2 months per year maximal. And we have to make sure that we warn the patient against continuing them. Some patients find them that they relieve their gastritis, so they continue taking them. So if we think of giving them aluminum-containing phosphate binders, we have to tell them that they should stop it after 1 month to 2 months maximally. And they suggest limiting dietary phosphate in combination alone or in combination with other treatments. And it's reasonable to consider phosphate source, as we'll find that vegetable sources of proteins are maybe contain more phosphate, but in the form of phytates, which is less absorbable and less bioavailable. So dietary phosphate restriction, again, is very important. The usual diet is 1,000 to 2,000 milligram per day. The recommended intake in stage 5 on dialysis is 800 milligram per day. In between, it should be maybe around 1,000 milligram per day. Dietary phosphate intake is generally proportional to protein intake. And classically, we have been telling our patients to restrict dietary protein, but this actually is associated with protein deficiency, protein energy malnutrition, and actually decreased protein is also unhealthy for bones. So the stress has been in the latest years on avoiding high phosphate diet and high proteins with high phosphorus to protein ratio. High phosphate diet includes all processed foods, all canned foods, sodas, and all patients, they are holding a bag of chips and a soda during their dialysis session, which are actually both very wrong for their phosphate content. Dairy foods, especially hard cheeses, processed meats have a lot of phosphate. Sardines, seafood, and shellfish, especially darker meat fish, chicken and beef liver and egg yolks, they have condensed phosphorus. But to avoid malnutrition, we can safely give foods with low phosphate to protein ratio, such as egg white and proteins from vegetable-based sources. Considering the cooking procedures is also important. Boiling leads to food demineralization, removing potassium and phosphate. Lastly, there were some trials about supplemented low or very low protein diet. But again, the latest guidelines that are being in review recently about CKD, they do not recommend low or very low protein diet. They actually recommend against reducing the protein intake less than 0.8 gram per deciliter, and they do not mention supplemented low or very low protein diet. Actually, the recent trend is in plant-based diet. It can diminish acid loss, which is beneficial to bones, and metabolic acidosis is frequently an overlooked point that affects bone health. And plant-derived dietary phosphate are mostly in the form of phytates, which are less bioavailable. So patients actually, we classically tell them not to eat any legumes and the بقوليات, but actually we may need to tell them to eat more in the future. Now he comes 1 year later, he stopped most of his medication, has not been following up. His corrected calcium now is 7 milligram per deciliter. His phosphorus is 5.8. His parathyroid hormone is 350. His alkaline phosphatase is 220. His vitamin D is low again. What would be the most appropriate treatment? So this is the classical picture we see most of our patients in, and I think, again, here we can give multiple things. And again, I see that most do not agree on what to give. So here the phosphate is high, and giving phosphate binder and phosphate restriction and phosphate binder is very important. Because of the low phosphate here, I would consider calcium acetate mid-meal not a very bad choice. The calcium acetate mid-meal would act as a phosphate binder and supposedly will not lead to significant absorption of calcium, so it may be given, but a safer option and a correct option would be sevelamer mid-meal if the patient can afford. Calcium carbonate supplementation, I would not recommend it if we give calcium acetate mid-meal. Also, calcium carbonate supplementation if the patient does not have symptomatic hypocalcemia or any tremors, any twitches. I would, especially after if he's on dialysis and he does not have any twitches on dialysis after correction of his acidosis, I would not recommend that we give calcium carbonate. Now, cinacalcet is an option. Alpha calcidol maybe here be problematic, but most people in this situation would give calcium acetate mid-meal plus or minus alpha calcidol, plus or minus phosphate restriction, plus or minus, if the patient it's possible, can give also cinacalcet. I think a very important point in this patient not to forget to correct vitamin D. So in every stage, maybe correcting vitamin D can correct the thing. So cinacalcet, again, one of you has suggested that cinacalcet would lead to lowering the calcium and also lowering the vitamin D. So again, it's not a good option, and I think we should reserve it to patients with higher levels or patients with end-stage renal disease. Yes, so cinacalcet, not an option because of the low calcium. So again, maybe here most of us would give either calcium acetate or sevelamer as a potassium binder. But if we give calcium acetate, we should monitor the calcium and the phosphorus maybe 1 month later. Phosphate restriction is very important. We could give alpha calcidol or again delay it till 1 month later when the phosphorus level has decreased. Giving vitamin D in this case, I think, again, may be an option. So phosphate binders, they should, it's very important to make sure that the patient is taking them with meals to limit the phosphate absorption by forming a non-absorbable compound with phosphate complex with phosphate. The binding ability actually is limited to 100 to 300 milligram of phosphate daily. Dietary phosphate restriction is still required. And generally, they are well tolerated, but again, they do not improve mortality. And these are the phosphate binders with the years they were developed in. There is aluminum-based binder, which is the cheapest, and it's very effective, but we should only use it for 1 to 2 months per year. The calcium-based binders, including calcium acetate and carbonate, which are cost-effective, most widely used, but we said they can give hypercalcemia. Magnesium-based binders, I don't know why we have not used them more frequently. Again, they contain calcium acetate, which has very low elemental calcium. So it has less risk of calcium, and magnesium reduces calcification and hypertension and mortality, but it's not commonly used. Sevelamer and lanthanum are the well-known non-phosphate binders. They are not associated with risk of hypercalcemia. Only sevelamer is present in Egypt, either in the hydrochloride or the carbonate form. The carbonate form has the benefit of correcting the present metabolic acidosis, but however, they are actually expensive. Lanthanum carbonate is not present in Egypt. Iron-based binders are also on the rise, but they are not present in Egypt. They have ferric citrate has the added advantage that it corrects iron deficiency. However, they are all associated with side effects. In aluminum-based binders, we fear for aluminum toxicity, which can lead to dementia, osteomalacia, and anemia. In calcium-based binders, again, there's risk of vascular calcification, arterial stiffness, and suppression of parathyroid hormone. In magnesium-based binders, there's a list of hypermagnesemia and diarrhea. Sevelamer and lanthanum, they are mainly associated with GI upset, which can lead to ileus and constipation. Iron-based binders also can lead to GI upset, including discolored feces. And if we use ferric citrate, it can lead to iron overload. Now, the latest systematic review that examined the effect of phosphate lowering found that most of them, their benefit is unclear. It included multiple RCTs. And actually, even non-calcium based phosphate lowering therapy were associated with increased vascular calcification in 3 studies when compared to placebo, but when compared to calcium-containing phosphate binders, they were not associated with they were associated with less vascular calcification. However, even in the studies that examined their impact on clinical outcome and cardiovascular endpoints found unclear effect. Manora is a rising star in this era. It was only FDA approved last year. It is an inhibitor of NHE3 that reduces intestinal sodium and phosphate absorption. It's a benefit that it's used only, it's taken only once, and it acts the 24 hours. So it will reduce the bill burden. We will wait till its introduction in the Egyptian market, and we will wait also for RCTs that may examine its role in reducing vascular calcification. To sum up, in pre-dialysis CKD, we have to start monitoring in stage 3A in adults, in stage 2 in children, and we should base treatment on trends. Parathyroid hormone, the optimal level high or rising, we should look for modifiable risk factors. We should avoid calcitriol and vitamin D receptor antagonist, including the alpha-calcidol, except in stage 4 and 5 with progressive RIVE. In calcium, avoid hypercalcemia and evaluate with phosphate together. Phosphate, lower elevated levels, it's very important by phosphate restriction and phosphate binders. And actually, if the patient reaches stage 5 and he has hyperphosphatemia, we may consider also initiating dialysis. So before we move from pre-dialysis patients, we take a patient that we, an example of patients that we often encountered, 47-year-old female, a slim female. She's diagnosed with nephritis.
Dr. Yasmine, while, please leave few minutes for some comments.
Okay,
Dr.
no
Tariq,
problem.
please unmute yourself. Dr. Tariq, any comment?
As regard our management, please, we care of our patient to avoid hypo or hypercalcemia. Also, on the other hand, we have avoid hyperphosphatemia. And as mentioned by Professor Yasmine, we have to maintain the trend of the PTH in the normal pathway according to the stages. And accordingly, we have to manage our patient, including medication and the drugs should be followed up on regular basis. Yes. Some colleagues mentioned as regards Zimbelar as alpha-calcidol as vitamin D analogs. He has the same pathway like alpha-calcidol as regards suppression of PTH, but on the other hand, he is less hypercalcemic, which is not suitable for our case with hypocalcemia.
Hypocalcemia. Okay. Dr. Muhammad Kamal.
I think the most important thing in pre-dialysis patient is to start early stage. I think leaving the patient at late stage will be associated with difficulty in management, and also bending on trends is very important, larger than the absolute values. I think this is the most important thing to focus on in this part of the lecture.
Let me ask a question, Professor Yasmine, about the use of sevelamer in pre-dialysis patient. Do you agree totally with this?
In some cases, if you have hypercalcemia or normal calcium level and elevated parathyroid phosphate, you will be faced with the choice either to give the patient short course of aluminum hydroxide or to you will have to give sevelamer. Of course, the problem we face with sevelamer and also with cinacalcet later is the cost. It's going to be costly for many patients, but actually they are safe, and it should be used earlier in some cases, especially cases with normal calcium, for fear of inducing hypercalcemia.
Maybe the first choice can be the first choice in pre-dialysis.
Well, the first choice in pre-dialysis, I think, again, depending on the patient and his calcium level. But again, it is safe to be used as a first choice, and the earlier we prevent hypercalcemia and the earlier we use non-calcium phosphate binders would be the better for the long-term outcome of the patients.
Okay. So please go.
Okay. So this is a 47-year-old slim female diagnosed with lupus nephritis. Received multiple courses of immunosuppressive induction over years, currently with no active disease. She's maintained on prednisolone, hydroxychloroquine, MMF, RAS blocker, and statin. She is stage 4 CKD with albuminuria stage 3, complains of bone pain and a recent Colles fracture 2 months ago. Beside the biochemical markers of CKD MBD, what would you order to assess her risk of fracture? I see most agreed it would be, and the second, so what we usually monitor in patients with CKD MBD is only the laboratory abnormalities, but we should also look at the bone abnormalities and the other vascular calcification we'll talk about later. Now, according to the KDIGO, they recommend that patients with CKD MBD and or risk factors or osteoporosis, we suggest BMD testing, bone mineral density testing, to assess fracture risk. because of, and it was not present in the previous guidelines, because there are now new evidence that BMD predicts fracture, even in patients without osteoporosis, with just CKD, MBD, it predicts fracture. And they have downgraded the bone biopsy. Now it's reasonable if knowledge of the type of renal osteodystrophy will impact treatment decisions. In the previous guidelines, it was very important, especially in patients where we are going to treat osteoporosis, to do a bone biopsy before treatment. And they suggest that it is enough to monitor or PTH plus alkaline phosphatase to evaluate the underlying bone disease and check the underlying bone turnover. In infants and children, we monitor bone by monitoring the linear growth in the first year, quarterly, and then at least annually. Now, what we, again, the core of CKD MBD and what we are looking to improve, not just the bone abnormalities, but the fracture risk. And the worse the CKD stage, the higher the fracture risk. And once the patient reaches stage 5, he has risk of fragility fracture of up to 5 times compared to patients with a GFR of below 60. And higher mortality risk is present after a fragility fracture, whether hip and non-hip fracture. And there is growing realization that osteoporosis and CKD MPD coexist in patients with CKD. Because of gender, especially in females, because of intake of corticosteroids that are given in a lot of patients, especially patients with glomerulonephritis, in patients with low BMI, and in patients of low history of fracture. These are all risk factors that increase the osteoporosis, and some have even suggested a new label that we should combine CKD, MBD, and osteoporosis together. We have, and DEXA scan is recommended, but again, it assesses refracture risk, but does not exclude renal osteodystrophy and does not identify whether it is hyperdynamic or adynamic bone disease. Now, how do we diagnose osteoporosis? It is if there is T-score, and T-score is the bone density compared to that of a healthy young adult of the same sex of -2.5, or low trauma, spine or hip fracture, or T-score between 1 and 2.5 plus a fragility fracture, and or a T-score plus a high FRAX score. And I saw that some have recommended the FRAX score, and FRAX score is a fracture risk assessment score that has been developed. However, it does not include CKD as one of the elements in it, and it's filled up and it gives a score. And this is an algorithm. It's not present in the guidelines, but it is suggested by Spanish group to be used in patients with CKD, that we should assess risk fractures and maybe assess FRAX score before taking DEXA scan. And if the FRAX score is high or intermediate, then we should move on to DEXA scan. And if osteoporosis is present or the FRAX score is present, then we should move on to pharmacological treatment. If there is no osteoporosis and there is low FRAX score, then we should move on to lifestyle. And these lifestyle measures we should also implement to our patients and recommend to our patients, which include regular weight-bearing exercise, healthy diet with enough calcium and vitamin D to, as we said, vitamin D in the general population at least reduces fracture risk, no smoking, and no alcohol. Now, the previous guidelines said that we have to do a bone biopsy before treating patients with osteoporosis. This has been brought down to just recommendation if the treatment will change, if the biopsy will change treatment. However, most treatments that we give for osteoporosis should be used with caution, and they should be used after correction of the biochemical abnormalities. So if the patient is hypocalcemic, correct it first, vitamin D deficiency, correct it first, try to bring the PTH lower, and try to correct also the phosphate. Now, bisphosphonate is the treatment of choice in the general population. It can be given up to GFR of more than 30. Some use it off-label in lower GFR. but and it can be used safely whether there is no evidence of CKD MBD and that it's preferable, or if there is some high turnover CKD MBD. But again, there is risk of its accumulation, so it's only recommended if the GFR is more than 30. Denosumab is safer in lower GFR. It does not need dose adjustment according to GFR, but this is associated with risk of hypocalcemia. And there was a recent article in JAMA that found that there were cases of severe hypocalcemia in patients on dialysis taking denosumab. So if given, it should be given with calcium and vitamin D supplementation, and calcium levels should be followed closely. Now, the duration in the general population, it's recommended that we give for 5 to 10 years and then follow up, but it's used, long-term use in CKD is not recommended. And again, we should continuously monitor the biochemical markers, and prolonged use of bisphosphonate and denosumab, as we'll see later, may lead to adynamic bone disease. So calcium ionized or total, I think in most our assessment for CKD MBD, we should be measuring total calcium, not ionized calcium. Ionized calcium can change in patients with CKD because it's dependent on the pH, and patients with acidosis will have high false calcium, ionized calcium. Unless we are looking for patient with twitches or patient with symptomatic hypocalcemia, then we are looking for or assessing ionized calcium. So we move on to patients with
few minutes.
Hemodialysis, but
Dr. Yasmine, Professor, few minutes, please.
Okay.
Dr. Tariq. Okay.
I have no comment.
Dr. Faisal Shaheen is with us and has a comment, please.
No, I have no comment, but it seems that the cases are quite good, well managed, and more information we need actually, especially to restrict some few drugs which we are abused, like alpha calcitrol and sinacalcid, and probably this is a very, very, very good. Thank you, Dr. Excellent, Dr. Yasmine.
I think this is an important message that we are overusing really alpha calcidol, and no need in many of our cases to use alpha calcidol in these cases.
Okay, from the chat, there are two questions from the previous case. When to consider using sinacalcid in pre-dialysis cases? Again, sinacalcid can be used in pre-dialysis, but in patients where they have rising PTH, but they have contraindication for alpha calcidol, like they have elevated calcium level or normal calcium level with high phosphate. And does not a native vitamin D elevate phosphate as activated vitamin D? Its effect is actually lower, but again, we should give it corrected, but not give too much together with in patients with hyperphosphatemia. And I don't know of a study that has examined its effect on phosphate in CKD patients.
Please correct this information for me if wrong. The native vitamin D is used mainly for it's actually mainly is in replenishment of deficiency, while the analogs alpha calcidol or something like this acts mainly for inhibition of PTH in CKD patient. Is that the difference is a real difference, or
agree? Native vitamin D deficiency should be replenished with vitamin D. As regard the suppression of PTH, both can work, but actually I cannot start with severe deficiency of vitamin D. I have to replenish it first.
Yes, so mean alpha calcidol or analogs acts mainly on suppression, cannot be used in
correction of native vitamin D.
Of course, the native vitamin D can act both, can well suppress. But my point is that the analog is mainly acts mainly on suppression rather than replenishment.
Yes.
Okay, thank you. So please go on.
So move on to dialysis case. This is a 67-year-old male patient on maintenance hemodialysis since 5 years. His original kidney disease is hypertension. He's not compliant on his treatment. His corrected calcium is 7.6, phosphorus is 5.2, PTH is 550, alkaline phosphatase is 320, and vitamin D is 20 nanogram per ml. So I'm glad that now doctors are including number 3, the phosphate restriction. As we said, we have to remember it. Here, I think we can start with calcium acetate together with activated vitamin D or alpha calcidol, which is the only analog that is present in Egypt. And maybe also we should not forget dialysis modification. And again, we should correct vitamin D by vitamin D supplementation. And sometimes patients with resistant hyperparathyroidism, it may be because of defect in vitamin D. So how can we adjust dialysis to improve patients? Now, playing with dialysate calcium is very risky, and the KDIGO recommend that dialysate calcium should be kept between 1.25 and 1.5 millimole, and they suggest increasing dialytic phosphate removal in the treatment of persistent hyperphosphatemia. We have to remember that high calcium dialysate leads to positive calcium balance on the long run. Hypercalcemia, vascular calcification, increases cardiovascular disease, but also has been associated with sudden cardiac death. And on the long term, it suppresses parathyroid hormone. Low calcium dialysate, on the other hand, may lead to hypocalcemia, may lead to secondary hyperparathyroidism, including increasing the parathyroid hormone, and it actually it can be associated with QT prolongation, myocardial ischemia, and hypotension. So keeping a net zero balance is preferable, but again, some studies has found that it is associated with poor outcome. And this is why probably over the years, the recommended calcium dialysate has changed over significantly. Now, the latest, and the Egyptian Society of Nephrology agrees with the KDIGO that the dialysate calcium should be 1.25 to 1.5, but actually some of the dialysates that are present in Egypt include calcium that is higher. So again, we may be, especially in patients with high calcium or with risk of high calcification, we should review the solution we have in our units. Now, phosphate removal through dialysis is dependent on multiple things: the type of dialysis, the session length, the dialysate flow, and the dialyzer efficiency. And this is a comparison in this table of the different methods that can improve phosphate removal. The best is the nocturnal or home hemodialysis of 8 hours nightly. It removes the best amount, the highest amount of dialysis, followed by post-dilution hemodiafiltration and extended diffusive dialysis. But again, in practice, in many of our units, increasing the session length or doing hemodiafiltration may not be a viable option. So this patient received alpha calcidol first as 0.25 microgram per day, but it increased his calcium, but also increased his phosphorus, then followed by 1 microgram per every other day. And I have looked for sources for this changes and for the dosing of alpha calcidol, but I have not seen any sources. But what we were told by our professors is that the daily small amount is can increase hypercalcemia and phosphorus more effective, more severely, while pulse of alpha calcidol is more effective as anti-parathyroid treatment. So it will reduce the parathyroid more. And he took his calcium acetate mid-meal, and now he presents 9 months later. He still complains of bone pain. What would be the answers? So now, because his calcium is normal, his phosphorus is still elevated, we should not be using calcium acetate. We should maybe move on again with phosphate restriction to sevelamer mid-meal. Alpha calcidol would not be a good option in this stage as well. It will increase calcium as well as phosphorus. Calcite would be a better option. Dialysis modification is still a viable option. So I think here we should move this patient from alpha calcidol to cinacalcit and move stop alpha calcidol and give sevelamer as a phosphate binder. So said in pre-dialysis there is no suggested PTH level. However, in stage 5 patients on dialysis, it is suggested to maintain PTH in the range of approximately 2 to 9 times the upper limit of normal, which is 130 to 600 picogram per milliliter. And they suggest that marked changes of PTH in either, even within range, in either direction should prompt initiation or elevation of therapy. So we should not wait till the level is above target or below target, but actually movements within the level initiate treatment. And they for PTH lowering therapy, they suggest calcimimetics, calcitriol, or vitamin D analogs, or even a combination of calcimimetics with calcitriol or vitamin D analogs. But they do not clarify which is the first line therapy. I have not used both calcimimetics with calcitriol. I would like to, after this case, to hear the experience of the floor. Now, if patients fail to respond, however, they do not specify how long would we suggest that they fail to respond. Some guidelines have suggested that if after 1 year there is no response, then we should consider parathyroidectomy. Now, calcitriol is not available in Egypt. Actually, the only available thing is the alpha calcidol, which is metabolized in the body into calcitriol. There are widespread availability of vitamin D receptors, including on the parathyroid gland, but also on the GIT. So it increases absorption of calcium and phosphorus from the gut with risk of hyperphosphatemia and vascular calcification. Synthetic activated vitamin D analogs and vitamin D receptor activators like paricalcitol, which is the exemplar that has been suggested by one of the attendings. VDRs, vitamin D receptor activators, are more receptor selective with less risk than alpha calcidol for hypercalcemia and hyperphosphatemia, but actually they are still associated with some risk of hyperphosphatemia and hypercalcemia and may lead to vascular calcification. Till a few years ago, we did not have the option of calcimimetics. Now we have cinacalcit, which is also available in the Ministry of Health على نفقة الدولة for patients on dialysis. It increases the sensitivity of calcium sensing receptors to extracellular calcium ions, and there is rapid dose-dependent response. We usually start at 30 milligrams, and we can titrate up. There is 60 milligrams, and there's 90 milligrams. And take caution, and again, follow up calcium and phosphorus. It can lower calcium as well as phosphorus, and it reduces high bone turnover. But however, it is generally well tolerated. With it can induce nausea and vomiting, and can induce, as we said, hypocalcemia. Ethyl calcitide is not available in Egypt. It is administered thrice weekly with hemodialysis session, allowing better drug adherence and reduction in the pill burden, tolerability, but actually with it. Now we have to remember one thing: early stages of secondary hyperparathyroidism, there is only diffuse hyperplasia of the parathyroid cells, and they respond to pharmacological therapy. However, if we do not treat it enough, it will lead to adenomatous tissue formation and nodular hyperplasia in the parathyroid gland. And these adenomas are resistant due to low expression of calcium sensing receptor and vitamin D receptor. And Dr. Husseini has said in the Congress that the number of, with good treatment, the number of should decrease. There should be cases that need, if we can
الفويس دكتورة ياسمين.
تمام. So in early stages of secondary hyperparathyroidism, they respond to pharmacological therapy. If we delay treatment and we're not cautious of the treatment, adenomatous tissue will develop. It contains less receptor and vitamin D receptor to be resistant to treatment, and in this case, and if we do good care, we may not as many parathyroidectomy. There is a lot of parathyroidectomy technique is best. Now, total parathyroidectomy was done usually, but again, because of would lead a dynamic bone hypoparathyroidism. So to preserve residual parathyroid tissue, subtotal parathyroidectomy or total parathyroidectomy was autotransplantation was suggested. And maybe a recent study found that subtotal parathyroidectomy is associated with higher risk of recurrence. And if there is recurrence and after subtotal parathyroidectomy, there's usually adhesions in the neck that make the repeated operation more risky. So actually total parathyroidectomy with autotransplantation maybe, or even total parathyroidectomy may be a better option. But again, there is controversy on which is best. To sum up this problem of high parathyroid hormone, we have to remember to correct correctable factors first, whether hypophosphatemia, hypocalcemia, or vitamin D deficiency. If we have low calcium and low to normal phosphorus, it is safe to give either calcitriol or vitamin D receptor agonist. If we have normal calcium and high phosphorus, it will be best to give calcimimetics. If we have no response to treatment, then we can consider parathyroidectomy. We have to remember whether we're giving calcitriol or alpha-calcidol or calcimimetic to discontinue if the PTH falls less than 100 to 150 picogram per ml, as we'll discuss later, maybe even at higher levels, patients with high risk for a dynamic bone disease, elderly and diabetic patients, to prevent inducing by our treatment a dynamic bone disease. Now, the patient received cinacalcet and sevelamer mid-meal. 3 months later, he now complains of repeated anginal attacks. And this is his profile at 1 year. His corrected calcium is now normal. His phosphorus is above level, but slightly above level. His PTH has improved, and his alkaline phosphatase has also improved. What would be the next step? So continuing cinacalcet would be still advisable. Again, switching to the cheaper activated vitamin D would not be an option here. His calcium is normal, and his phosphorus is just above normal. continuing sevelamer or continuing phosphate binder and phosphate restriction is also maybe an option. Again, improving dialysis, prolonging the dialysis sessions to improve his calcium would also be an option. But he has now repeated anginal attacks, and maybe it's time, to discuss vascular calcification. Now, again, the KDIGO suggests that lateral abdominal radiograph can be used to detect the presence or absence of vascular calcification, and an echocardiogram can be used to detect the presence or absence of valvular calcification as reasonable alternative to CT-based imaging like coronary artery calcification. And if patients have vascular or valvular calcification, they should be considered at highest cardiovascular risk. And it is reasonable to use this information to guide management. However, the universal use of screening for cardiovascular calcification in CKD is still controversial because we have no specific therapies that attenuate vascular calcification. That's why it's not a strong recommendation. They suggest that they can be used. But if they are present, we should maybe use this information to avoid treatments that may enhance vascular calcification. Now, cardiovascular calcification in chronic kidney disease may be in the form of either intimal calcification with atherosclerotic process, in the form of medial calcification, in the form of valvular calcification, or worst of all, in the form of uremic calcific arteriolopathy or calciphylaxis. Now, as we said, we have no effective intervention to attenuate vascular calcification. That's why maybe the most important point that we can take from this lecture is to prevent vascular calcification from the early stages of pre-dialysis CKD. Now, this is the biggest systematic review till now that has examined interventions to attenuate vascular calcification, and they conclude that there is insufficient or conflicting data. However, they have set three categories of treatments, treatments that probably reduced vascular calcification, but say that studies are still small and of short duration, treatments that possibly reduce vascular calcification, and treatments that are unlikely to reduce vascular calcification, which include the, unfortunately, sometimes prescribed vitamin K2. Now, probably reduce includes magnesium, sodium thiosulfate, kidney transplantation, increasing hours of dialysis, including nocturnal dialysis, and non-calcium-based phosphate binders when compared with calcium-based binders. However, when compared to placebo, they did not show such an effect. The possibly reduce include anti-resorptive therapy and calcimimetics and low dialysate calcium. So until now, we have no effective treatment to correct vascular calcification, and our best strategy should be to prevent it in the first place. The patients changed treatment several times. Cost was too high. Some medications were recommended by the doctor of the dialysis unit. Some were recommended by other patients in the unit. He presents 2 years later with vertebral fracture. What should be the next step? His calcium is high, his phosphorus is low, his PTH is low, and his alkaline phosphatase is low. So again, it's very important in this patient to stop calcium, stop alpha-calcidol, stop sinacalcet if he's taking it. Phosphate restriction is not important at this point. And actually, the only treatment for this condition would be, of these treatments, would be teriparatide. Now, we have to remember that our patients are between two extremes, and they are along this spectrum between low turnover bone disease and high turnover bone disease. Most of them start in the high turnover region where there is increased bone resorption and formation, but more resorption, and low turnover where there is low bone resorption and formation. And as we said, the laboratory indicators can be that in high turnover, there is high PTH, high alkaline phosphatase, while in low turnover, there is low PTH and low alkaline phosphatase, usually with high calcium and normal or high phosphorus. Now, once we give treatment for high turnover disease, we, whether calcium, calcitriol, aluminium, or high dialysate calcium, we move the patient towards the low turnover spectrum. And low dialysate calcium, negative or zero calcium balance, as well as hyperparathyroidism, move the patient towards the high turnover region. And actually, we should keep the patient in the middle between the high turnover and the low turnover in the mixed area by limiting treatment or by following up treatment. Bone disease is multifactorial. It includes either by calcium overload, by excessive suppression of parathyroid hormone, by sinacalcet or by calcitriol, or by aluminum toxicity. But it can also happen because of old age, because of diabetes mellitus, because of gonadal dysfunction, and because of also malnutrition. And there is rising prevalence actually because of the increasing age and the higher prevalence of diabetes, and it is associated with higher mortality, especially if it is associated with calcium overload. So, and diagnosis of adynamic bone disease, the gold standard is bone biopsy. However, bone biopsy, it has high cost, and there is lack of expertise, and it is invasive, and actually there is controversy about the levels of different markers and different levels that should be in it. So there is little use for it in some cases, but again, in some centers it is used. And the best markers or the cheapest markers are the parathyroid hormone and alkaline phosphatase for us to check the turnover, whether it is high or low. There is also bone formation markers and bone resorption markers, but actually in the KDIGO guideline, they recommend against their use. Radiology, DEXA scan, and CT, they can detect some elements, but again, they cannot, and they detect whether there is the risk of fracture, but they cannot differentiate adynamic from hyperdynamic bone disease. Now, adynamic bone disease, when present, is very difficult to treat. And again, the best option is to prevent it by avoiding its risk factors, including aluminum exposure, calcium overload, avoiding oversuppression of parathyroid hormone, by tolerating slight increases in parathyroid level, especially in elderly and diabetics. That's why maybe it is recommended not to lower the parathyroid level to below 200, to monitor parathyroid hormone levels over time and to treat trends, to consider subtotal or parathyroidectomy or total parathyroidectomy with autotransplantation, to target factors that may contribute to PTH resistant like hyperphosphatemia, malnutrition, and inflammation, to avoid excessive use of anti-resorptive. Excessive use of bisphosphonate and denosumab can also lead to adynamic bone disease. The only treatment for adynamic bone disease are bone builders or osteoanabolics that include teriparatide, recombinant parathyroid hormone, the newer abaloparatide, and romosozumab, sclerostin immunized monoclonal antibodies. However, they are all unavailable in Egypt. So our best option is to prevent the patient from reaching the adynamic bone disease stage by maybe stopping treatment at higher levels of parathyroid hormones.
Okay.
Should we open?
Any comment, Dr. Tariq, please?
For discussions?
Actually, we have to avoid adynamic bone disease, avoid excess calcium, over use of alkazidol, And during our management, to control or to correct the calcium, phosphorus, and PTH, we have to monitor our patient on monthly basis, not to postpone for 3 months. Many thanks.
Dr. Yasmine, regarding the point of the combined use of vitamin D receptor activator and cinacalcet, I used it many times, and I think it is rational to combine both, because vitamin D receptor activator can nullify the hypocalcemia that is predicted to occur with cinacalcet, and also cinacalcet reduces serum phosphorus that can be increased with the use of vitamin D receptor activator. So I used it many times, and I think it is guided by the monitoring of the calcium, phosphorus, and PTH, and no problem with the combined use.
Okay, before I ask my question, I would like to thank our coordinator today, Dr. Mu'tasim Al-Sayed, for his work, all of his work regarding this session and all of other sessions and all of the previous period of CME chapter activities. And I would like about the experience, ask a question about the experience of use of teriparatide in such cases.
Well, I have no experience with teriparatide, and there is a question about how long should the teriparatide be used. I think the problem with denosumab, teriparatide, and bisphosphonate that they have to be used for a very long term to make action. It takes years to diminish the buildup of bones and to improve the bones again. It will take a long time. I don't know if any of our colleagues have experience with teriparatide in a case of adynamic bone disease.
In addition to its cost,
of course.
What I know that is, as you said, it needs a very long time, and in the face of its high cost, it will be unsuitable to be used for this long time, depending on this high cost.
So I know it's been a long day, but we have only the 2 cases. Again, they are the extremes of treatment, and our aim of treatment should be to prevent reaching these stages. So a middle-aged woman with end-stage maintenance renal disease on maintenance hemodialysis, she's diabetic, has cirrhosis, and secondary to hepatitis C. She recently started warfarin for rapid atrial fibrillation. Her current medication include calcium acetate 2 capsules 3 times mid-meal, alpha calcidol 1 microgram once per day, and she comes complaining of tender violaceous to hyperpigmented plaques and nodules on the posterolateral thigh that are and hyperpigmented retiform patches and erosions. So what do you think the diagnosis is, and what should be the treatment? So this patient, again, has one of the complications that we commonly oversee, which is calciphylaxis, and especially in diabetic patients, it can be seen, and it's maybe here induced or precipitated by the intake of warfarin, which increases the risk of calciphylaxis. Calciphylaxis or calcific uremic arteriolopathy is the result of deposition of calcium in dermal and adipose microvasculature. It's associated with high morbidity and mortality, and the main cause of mortality in these cases is sepsis from infection of the ulcerations. So it is very important to correctly diagnose and treat this condition. Risk factors are multiple, and actually there are few cases that can even happen with normal calcium and phosphorus, but most cases are, again, because of poorly managed chronic kidney disease related mineral bone disease. There is a lot of risk factors like female obesity, hyperparathyroidism, warfarin, steroids, vitamin K deficiency, recurrent hypotension. And its diagnosis is mainly based on high clinical suspicion. It's suspected and should be suspected, although the most common sites are the lower extremities and the abdomen. It should be suspected even if they appear on other sites. There is actually coburnization with calciphylaxis, where it can happen at the site of any trauma. And sometimes we may need biopsy, and it's in this case, it's recommended to take punch biopsy, again, to avoid inducing calciphylaxis at the site of the biopsy and preventing the poor wound healing. And it can show circumferential stippled basophilic deposits, and there may be also fibrin thrombus. And there is actually a role for imaging, whether plain radiograph, but it's done with special exposures. Usually these were taken with mammographic exposure to see the small vessel calcification, which can be seen as net-like pattern of calcification in the subcutaneous tissue. But and what I found interesting is that they also can be detected by point-of-care ultrasound as hyperechoic spots and linear hyperechoic bands with posterior acoustic shadow in the dermis by the superficial probe. Management of calciphylaxis is again very difficult, and that's why prevention is the most important part of its treatment, by first mitigating risk factors. In this case, as you all said, withdrawal of warfarin, vitamin D, and calcium. They all increase it, correct, maybe give non-calcium phosphate binders, give cinacalcet if there is hyperparathyroidism, optimizing the markers of CKD, MBD, optimizing dialysis, whether the dose or the dialysate, avoiding high calcium dialysate, and kidney transplant can be in these cases. Excellent wound care is also very, very important. And as we said, the main cause of death is because of sepsis from this wound infection. Enzymatic and atraumatic debridement has been suggested to limit the coburnization and the extension of the regions by the surgical debridement, or either the use of judicious surgical debridement. There has been also some studies with hyperbaric oxygen therapy, and supportive therapy is very important in the form of good nutritional support and adequate analgesia. Its management is by IV sodium thiosulfate, which I hear that is not easily found even in Egypt now. It's very difficult to obtain. And bisphosphonate can be used, and there is a new drug, the SNF 472, which is being studied both for calciphylaxis and for vascular calcification. We have comments before we move on to the last case.
All local care, all are going with, as you said, measures of treatment. No comments or recent questions. Diagnosis calciphylaxis, stop warfarin from Dr. Manal Deep, and stop warfarin, calcium, active vitamin D, or of check hypercalcemia, etc., etc. I can't see any specific comment except for all right answers for your question. So proceed, please.
Okay. So we move to the last case, 66-year-old male patient, end stage on maintenance hemodialysis since 15 years. Original kidney disease is unknown. He has been on cinacalcet for a year, but his PTH is still elevated. Refused doctor recommendation to do a parathyroidectomy. Complains of severe bone pain and tender swelling in the wrist and arm. His corrected calcium is 9.2, phosphorus 5.8, PTH is 1,550, his alkaline phosphatase is 620. What is his diagnosis and what would be the treatment? So, yes, as all have agreed, this is a classical case of brown tumor, which can occur in 2% of patients with secondary hyperparathyroidism, and it presents with chronic bone pain, fracture, and deformities. Usually these patients have severe hyperparathyroidism, and in the X-ray they have lytic or multilobular cystic alterations. This is the gross picture of one of the bone of tumors, a bone containing the tumor, and there is brown pigment that gives it its term brown tumors. And histologically, they are highly vascularized tumors with clustered osteoclasts in a hemorrhagic background with brown pigment from the hemosiderin. And these were pictures from a case study that was presented by Dr. Tariq Tantawi to me to put in the presentations. Although the cases are few, but actually they are miserable, and they have deformities that sometimes even after correction of their hyperparathyroidism that persist and that need orthopedic surgery. Now, the pharmacological prevention is by treating secondary hyperparathyroidism, giving calcium mimetic, correcting vitamin D deficiency, giving bisphosphonate and denosumab may improve the condition, while the surgical treatment is very important in these cases if to do parathyroidectomy if they're not responding, to do cyst drainage, and sometimes if there is large deformity or defect in bone, these patients may need bone grafting. So this was the last case. Again, the last few scenarios, the adynamic bone disease, the calciphylaxis, the brown tumor, they are very difficult to treat, and they are signs of unsuccessful management. And our role and our aim should be to prevent these complications, as said, to keep the patient in the middle between high turnover and low turnover, to avoid both sides and to avoid both complications. The take-home message is you should start early in patients with stage 3A. You often miss screening patients at such an early stage, but our treatment should start at this stage. We should treat trends rather than individual values. We should always put calcium, phosphate, PTH, alkaline phosphatase, and vitamin D levels into consideration. We should by all means avoid hypercalcemia, hyperphosphatemia, too high and too low parathyroid hormone, and we should monitor closely after treatment. Maybe we should always tell the patient these treatments, they should not go on for life. You have to monitor them and monitor the investigations and maybe stop them or take them for a while and don't continue taking them indefinitely. We still have many unanswered questions, and we still are not improving the core outcome. We're not improving cardiovascular disease, fracture, and mortality, not consistently. And maybe we are too late. The early bird catches the worm, and prevention is better than cure. Thank you, and sorry for the prolonged day. Does anybody have any questions?
Thank you, Dr. Yasmine. Dr. Tariq, any comment on Dr. Muhammad?
Actually, you cover all the items and all the bad things that can patient suffered from CKD pulmonary disorders. I would like to add only in case of severe secondary hyperparathyroidism, what I mean PTH above 1000, we give a trial for Cinacalcet, and if another combination therapy we can add. And we have to follow our patient closely on monthly basis. And if the patient not responding, we have to go forward for parathyroidectomy, either subtotal or total, plus subcutaneous autotransplantation. Also, we have to avoid adynamic bone disease. And in early cases for CKD, don't rush with the use of calcium-based phosphorus binder or an active form of vitamin D before you are doing your investigations, and there is indication for the usage of these drugs. Yes, and at the end, thank you.
Thank you. Ayman Rifai, please.
Thank you very much, Dr. Yasmine. I really enjoyed your presentation. You addressed one of the most important issues in our nephrology practice in very practical way, delivering many important messages. which if probably applied, I think, of course, this will improve our management plan and management of the CKD MBD. In the first case, you showed us clearly the importance of screening in the early stages. You stressed that we should avoid hypercalcemia, which is usually iatrogenic due to our abuse of the calcium and vitamin D in order to avoid the vascular calcification and its sequelae, fatal sequelae. Actually, the phosphorus, which is the forgotten cation in our measure, and is yes, it's a major player in the pathogenesis of CKD MBD. That restriction is very important. As we know that phosphorus is an independent risk factor for cardiovascular disease. In case 2 with CKD MBD, especially in patients with original kidney disease, which could cause or its treatment osteoporosis, like the case of systemic lupus with steroids, assessment of fracture or risk fracture and osteoporosis is very important with the fracture risk assessment score. DEXA scan is an important complementary investigation in this situation. You stress that correction of biochemical abnormalities is very important prior to rush to the anti-osteoporotic drugs, bisphosphonates and others, and bone biopsy. Although it's advised by recommendation, yet I think it's still impractical in view of being invasive, costly, and it needs expert, a lot of experience in the interpretation of the biopsy. Case 3 with hemodialysis was fantastic, and you said that playing with the concentration of calcium in the dialysate is very serious. We have to stick to the 1.25 to 1.5. We have also stick to the target of BTH 130 to 600 picogram per ml. In this stage, calcium mimetic is effective, and we should always consider parathyroidectomy in resistant cases. And you showed us actually a very nice algorithm for a patient with high BTH. 2 conditions that we should search for and take care about the prevention, as there is no cure. Both the vascular calcification, in spite of some data about the use of vitamin K in prophylaxis, and the other is the adynamic bone disease. Case 4 and 5, you give us a very frank examples of the true malpractice in management of our CKD patient. I thank you very much, Professor Yasmine, for this presentation and these important messages. And before I finish my comment, I would like to thank and congratulate Professor Yasser. Congratulations for the success in the election. And actually, this success reflects the awareness and trust of our ESNT members about persons who saves no effort in conducting and promoting the society and the CME. I would like to congratulate him also for the success of the 6 interactive workshops during the ESNT Congress with the very positive feedback from the attendee. And finally, thank you, Professor Yasser, for the non-stop activities. Here we are just few days after the ESNT big events. So please go on and always keep it up. Thank you.
Thank you, Professor Ayman, for your resume for the cases, which made us more in enjoying these cases and remembering what are the hot points illustrated. And thank you for your extremely nice words for me that I hope I deserve. Before I close, Dr. Muhammad Nassar, do you have a comment, final comment?
Yes. Dr. Yasmine, thank you for this elegant and highly illustrative presentation as usual. Actually, I have one question. From your point of view, do you recommend the routine measurement of serum magnesium and magnesium supplementation? I think it is not illustrated in details in the guidelines, but I want to know your idea about this.
Again, especially in dialysis patients, keeping the magnesium is very important, and I think again it's one of the things that need to be added to the guidelines, and it should be monitored. And personally, after reading or after preparing this lecture, I am willing to use calcium citrate, magnesium acetate more commonly as a binder, because it has the advantage of reducing vascular calcification. But again, although it has a potential, actually the studies are still small sized and with shorter duration. So they are not, it has the best backing data, but it should be used more commonly, especially if the patient is hypomagnesiemic, because hypomagnesemia and hypermagnesemia are both associated with mortality in end-stage renal disease patients. So at least we should maintain it in the normal level, and maybe we should give magnesium a chance as a phosphate binder and as maybe prophylaxis for vascular calcification.
Okay. I have another question about the purity of dialysate and the polyfactor unit and the toxin content. I think in Egypt we measure, or we are interested in the whole culture of the dialysate, micronutrients concentrations or trace element concentrations, but we don't focus on the purity of dialysate by using the standard definitions of polyfactor unit. Do you suggest use of it in the assessment of patients with a dynamic bone disease or severe or refractory hyperparathyroidism? Can it be a cause, and can it be managed and improve the management in these cases?
ايه بالظبط in the dialysate? What in the dialysate?
Purity of dialysate, like polyfactor unit or toxin content. We don't take routinely. Yes.
Is one in dynamic bone disease, and maybe not the purity itself, but actually measuring the CRP in patients to detect inflammation, which will increase adynamic bone disease, increase the risk of adynamic bone disease, is important. Now, in all units, there is some control by the Ministry of Health, but know that to improve that, we should also measure the endotoxin level, if there is ultra pure dialysate, and ultra pure dialysate and it has its advantages in reducing inflammation and reducing dynamic bone disease.
So you agree with me? It should be emphasized more with more focusing on this item, and be associated with difficult and resistant cases.
Yes.
Thank you again, Dr. Yasmine. Thank you.
Thank you, Professor Muhammad, Professor Yasmine, for your last interaction. And no more comments and no more questions. And excuse me to close this session. Thank you for my co-moderators, Dr. Tariq Tantawi, Dr. Muhammad Kamal Nassar, for their share and interactions. And thank you for all our attendees for their active share and for interaction with Dr. Yasmine during her continuous questions and answers. I think every question received more than from 8 to 10 answers. Thank you for all our professors attending the session: Professor Salah Naga, Professor Ayman Rifai, Professor Faisal Shaheen, Professor Manal Deep, for their presence and their interactions. And thank you again, Dr. Mu'tasim Sayed, for our coordinator today, for his work regarding this session. excuse me, to close and announce about the coming session to prepare our patients in Ramadan regarding kidney disease in Ramadan, how to deal with patients with kidney disease before Ramadan, and diabetic patient in general, how to deal with our diabetic patients in regarding Ramadan. Of course, we are internist first and nephrologist second, and we deal with our diabetic patients and manage them independently, so we are to prepare them for the holy month. Professor Ahmed Al-Qurai'i and Hussam Ghazi will speak about these two topics in the coming Wednesday, inshallah. Thank you. تصبحوا على خير والسلام عليكم ورحمة الله وبركاته.
شكرا.
السلام عليكم.
كل سنة وأنتم طيبين. شكرا. تصبحوا على خير. مع السلامة.